This is Tiffany Robinson, Training Specialist for ComForCare Franchise Systems, and welcome to the ComForConnections podcast. In this Masterclass episode, Best Practice Considerations for Aging Services Pros, Restorative Care to Maintain and Improve Function, I am joined by Sue LaGrange, Chief Nursing Officer of Pathway Health, a sought-after speaker and industry leader in the senior services space. Listen to this Masterclass episode as we share insights into the components of nursing restorative care and services, review evidence-based strategies to educate caregivers for implementation, and discuss the benefits of restorative care and services to help older adults thrive.
So hello and welcome to Best Practice Considerations for Aging Services Pros, Restorative Care to Maintain and Improve Function. This presentation today will provide you with some user-friendly strategies that you can utilize when caring for individuals who may have possibly declined in their activities of daily living, or otherwise known as ADL function. Also, for those who have the potential to be able to improve function, and even for those who need assistance with maintaining their current level of functioning. And we do this in order to be able to do as much as possible for the residents, for the patients or clients to be able to do as much as possible for themselves as well as for their own safety. We have two speakers for today's presentation, myself and Tiffany Robinson. My name is Sue LaGrange, and I have had over 30 years of post-acute care leadership experience in which I have assisted the organizations in regulatory, clinical, and operational turnarounds. In over 20 years with Pathway Health Services, I have worked on quality improvements in a multitude of organizations, and I also am a trainer nationally in infection control, clinical management, restorative nursing, and I'm also a certified Interact Champion Master Trainer. And I am honored to be presenting today with Tiffany Robinson. Tiffany has worked for ComForCare for 18 years and has a BA in social work from Oakland University in Rochester Hills, Michigan, and a certificate in instructional design from the University of Maryland. In her role at ComForCare, Tiffany has worked as a training specialist, specifically with onboarding new offices and helping to facilitate their training programs. We are both very happy to be here today to share some key strategies on restorative care. I know many times people say that they understand the importance of restorative nursing interventions across the care continuum, but if we step back, do people really understand how crucial it is to have good systems in place? Many times our patients or clients have had a health event, whether they go home from the hospital with services or they went from the hospital to a nursing facility and then home with services. And even in some cases, they have had a health event in which services are now necessary in the home. And as you all know, in a good number of instances, that individual, that client or patient, has lost some function that has been part of their care plan prior to that care transition, and now can very well benefit from having those services extend into the care in the home in order to be able to keep that individual at their highest level of functioning. And this is going to be so important, not just for function, but for safety and for that psychosocial component of health as well. And when a patient or client has received services in another setting, it will be important for us during that transition of care to receive that good communication on what services were provided, how that individual, that patient, that client progressed for those services, and what interventions worked and what did not, in order for us to have a really good understanding of how to assist that individual in moving forward. So when you receive a new client into your services, there are times when that transition can be overwhelming for both the patient and their family. And there even may be a natural decline as everyone tries to figure out what is their new normal. And this is why it is important to understand what restorative nursing is, the importance of good transition of care communication in order for the team to provide quality services for optimal outcomes. So today, we will be discussing how we can work together with our team for those quality outcomes and for patient satisfaction. Now, we know the last several years, if you look back, the last 4 years have really been instrumental in care needs for people because individuals were less mobile during the pandemic. And many times, some of those individuals experienced a decline in function because they were not moving around as much. And the focus was more on infection prevention and control because it had to be at that time, right? We were experiencing, that pandemic. And so that infection control, that was really more of a focus. And then we were dealing with staffing challenges that were realized in all healthcare settings. And in several healthcare settings still continues to be a challenge that we're working with moving into now outside of that pandemic. So we know that some of our individuals we care for, their function may have declined. And so education and training will be essential for our staff because we have new staff. Staffing situations have changed in many organizations. And so we have systems in place now where we're working on making sure that all of our new staff are well educated and competent in their roles, and function will be part of that. And then some may also be looking at agency staff to provide services. This has also brought some new challenges to our organizations. And in many instances and situations, it really has left us with that need for a good restorative nursing program to implement for our individuals when it is assessed as necessary. Now, certainly, every client or patient will not need restorative services, but there will be those who can benefit from those services for quality outcomes and for, once again, that patient satisfaction. So let's start out with the purposes of restorative nursing services. And they are multifaceted. And so the successful restorative program will help those patients or customers to, first of all, attain and maintain their highest level of function. Because as we know, if we don't use that function, we lose it, right? And most people want to do as much as they can for themselves. And in many cases, in order to be able to stay in the home, it will be essential for these individuals to be able to safely do as much as they can for themselves. And practice and repetition of exercises and interventions and approaches will be important for several individuals to be able to continue to do as much as they can. The second is to maintain or reattain that dignity and self-worth, because as we know, most people want to do as much as they can for themselves. In fact, it is well known that individuals that can take care of themselves and move around independently, as well as do as much as they can, have a higher sense of dignity and self-worth. It also can help with preventing complications of chronic conditions, because all of us know at any age, as we exercise and move around more, unless it's contraindicated, this will help all of our systems work better. It will help our lungs work better. It will help our hearts work more efficiently, which will help with circulation. It will help our joints and muscles to be improved. Even our GI system will work more effectively and efficiently if we are working and exercising and moving around. And of course, it also helps with our minds, right? And then it prevents deterioration, because on the other side, if we don't move and we don't exercise and we don't use our muscles and joints, we become stiff. We become at risk of developing, outcomes that are not satisfactory, such as pain, contractures, even falls, balance and safety concerns. And then we will require other people to take care of us if we lose that functional ability to be able to comb our hair, brush our teeth, walk, or even transfer. And then lastly, to reduce the level of care required to perform daily tasks. Because as we continue to teach and work with individuals, they become more independent, which then results in less need for caregiver, physical support, family, and others to perform the cares, as the individual becomes increasingly able to do more for themselves and will be able to stay in their homes many times longer because they are able to do those skills as much as they can by themselves. So let's talk about getting back to the basics of nursing, right? Because restorative nursing is part of the basics of nursing. And the program should be based on the individual's identified needs and preferences. And this will include discussion with that patient or client and the family or a significant other to have a good, solid, comprehensive assessment, and then to make sure that the individual can benefit from those restorative nursing interventions. Also, many times outside of your services, they could be coordinated with formal therapy that a physician has ordered. And they can be started either after, formal therapy discontinues services, and then your staff can actually work with some of those interventions, or even in some cases, restorative services can be in conjunction with formal therapy. And this is also an important step because therapy are the experts and will have valuable information on what has worked, what interventions have not been successful or safe. They can provide some tips and good strategies for caregivers that they can use that will provide a good transition to caregiver interventions. Also, restorative nursing interventions need to be planned and organized and documented, right? And that's going to be important too, because routine care would be doing those things for the individual, whereas restorative services are planned and are in addition to routine cares. And these interventions then are approaches that many times need specific direction, repetition, and learning, and even teaching with those patients in order for the individual to become stronger, and with the goal of being able to eventually perform as independently as possible. The program should also be aimed at improving or maintaining functions. So, for example, if we're improving the number of steps that they can walk, it would be that improving goal. But if we want to maintain function, would be someone who we don't want to see decline in their walking ability, for example. And then, of course, care planning will want to identify those individualized goals and interventions, and we need to make sure that we have a system to review those on an ongoing basis and make revisions as necessary, because they need to be based on really a team approach on any type of caregivers, if therapy is involved, and we want to include the preferences of that patient or client and the family, or any home caregivers as well, to be sure that everyone is on the same page to be able to lead to successful outcomes whenever possible. So let's talk a little bit about promoting function, because promoting that higher level of function will require identification of what that individual actually can do for themselves. Not what we think they can do, but what they actually can do for themselves, using a good evaluation to make sure that we have processes in place so that we know what they can do. We also need to identify what assistance they need and at what level. And in what assistance do they need in terms of caregiver assist, family assist, equipment necessary? Do they understand how to use the equipment? Or is teaching part of our process working with them? Is it available and in good repair? Is it the right equipment? Are they safe using the equipment, or do they need more support? Also, 24/7 view must be considered when we're teaching and talking because their function may vary. Sometimes people are more independent after they get moving around a bit in the morning, but they get stiff a little bit when they first get up, or maybe at the end of the day or in the evening, they tire easy and they may not be as safe as they were earlier in the day. And then, of course, multiple sources are required in that assessment process. And as we discussed earlier, that transition of care communication is important. If they are seeing formal therapy, even talking with them, working with other caregivers, families, and significant others in order to make sure that whatever care plan we have in place is meaningful and realistic for that patient or client. So potential causes of loss of functional ability, of course, we know if you have someone new, for example, that transition of care, you may see some loss of functional ability because, that transition might be a little overwhelming. Also, if you have someone that has a new health condition, or if they have an exacerbation of a current health condition, we might see a decline in their function that may need to be addressed. So there are other potential causes such as cognitive deficits. Sometimes when we have an individual that has a decline in their cognitive status, they may forget how to complete one of their ADL tasks in the right sequence, or they could forget to do them at all. Sometimes they don't even understand why they need to do the importance of an ADL task. And they sometimes also may forget the safety steps with transfers or the use of equipment such as a walker or a wheelchair, or even sometimes sequencing to brush their teeth. It could be due to physical or neurological deficits. It could be due to stamina because of the individual's health condition, or sometimes even lack of exercise, as we talked about earlier, can cause deficits in their stamina, which can give you as a caregiver an opportunity to improve that whenever possible. Sometimes it's muscle tone from lack of use, another area that can give you an opportunity to improve in conjunction with the provider and therapy input if possible. Also balance, right? Because as you know, another cause of loss of functional ability is because as people become unsteady, they tend to limit getting up as much for fear of falling or even walking as frequently. And then bone strength as we age, or even side effect of medications. So for example, some medications can cause that orthostatic hypotension, which can lead to dizziness and falls, or medications that cause drowsiness, and then function can also be limited. So these are some of the causes, and there are more, but these are some of those causes that could contribute to the loss of functional ability. So there will be individuals that have lived in long-term care setting and have received both formal therapy and restorative nursing in an effort to improve their function enough so that they can be discharged to home, and many times with services, before you even see them. So it is important that you have an understanding of what type of restorative services that they may have received in order for you to monitor and care plan those services so that you can reinforce those approaches once that individual is in the home to either prevent decline, or if you see that resident or client or individual or patient is starting to decline, you can then observe and identify that decline quickly enough to be able to put your services in place. So let's discuss what services that they may have had in a nursing facility or another healthcare. So we will address the specific components of the restorative program that could have been implemented prior to your services, because this will give you a good idea of what types of services you can use if necessary if you notice that your individual has functional needs and you want to keep them at their highest level of functioning. So let's take a look at some of the restorative programs that may have been used. So the first one is toileting. Whether it's a bladder or bowel toileting program, these are programs that are implemented based upon an assessment of an individual who has incontinent episodes. And this program involved an evaluation of their pattern So finding out exactly when they typically void, as well as an assessment that looked at their diagnosis, their function, their medications that could have contributed to their incontinence, evaluation of their patterns, and determination of a type of incontinence, whether it's stress, urge, an overactive bladder, overflow mixed, or a temporary, sometimes known as transient, or even functional incontinence. And from there, an individualized program may have been implemented with the goal of reducing incontinent episodes, because we all know that a good toileting program that can reduce incontinence can reduce potential safety concerns. Think about how many times falls happen when an individual is getting out of bed to go to the bathroom, or rushing to the bathroom, or slipping on urine, or getting off the toilet, right? So reducing those incontinent episodes is also important for that individual's dignity. Next is passive range of motion, or PROM, which many times is planned and implemented for someone who is not able to participate at all. So if you have someone, for example, who has left-sided hemiplegia, who is completely dependent on staff to perform range of motion, there is no active participation by that patient or client. You may or may not see someone who has that need. Now, active range of motion is where an individual participates in the range of motion exercises with the caregiver direction, who prompts and provides that positive reinforcement. Another example of active range of motion is called active assisted range of motion, also known as AAROM, in which the caregiver verbally directs and prompts, but at times may put some hands-on to assist that patient or client to complete the range of motion exercises. The difference between active range of motion and passive range of motion is that with passive range of motion, that individual, that patient, that client has no involvement in the exercise, so that you may not see too much of. Next is splint or brace assistance. If you have an individual in your care, in the nursing facility, the caregivers may have provided a restorative program that either taught them the care and application of the splint or brace, where they actually put that brace on, or they taught that patient how to prepare the limb, the hygiene needs, proper application, as well as teaching that patient how to monitor for any pressure areas. And so if that's the case, you could work with that individual to see if they still continue to be able to prepare their limb, monitor their hygiene needs, monitor for pressure areas, and that they are properly applying that splint. Also, bed mobility, which is a program that's a planned, organized program to improve an individual's ability to safely move in their bed from side to side and even scoot up in their bed safely, which many times when they, prior to coming into your services, may have been a combination of staff or caregiver assist with patient instruction and then exercises to become strong enough to move in bed. So, for example, if you're working with an individual who might have some difficulty, they may need a trapeze, for example, to help them to become strong enough to move up and down and up and turn and up and down in bed so that they can, and also even teaching them to feel for the side of the bed so they don't fall out. Next is the transfer program that focuses on exercises and practicing safe transfers between chair and wheelchair or bed and chair. Also, walking or ambulation program. And that can be either working on improving function or maintaining function. And sometimes even working with people where it would be reminding them and putting in the care plan, for example, to lift their feet, because some people drag their feet, and to stand up straight and look straight ahead, and really giving them some good safety instruction on how to utilize equipment if they're using a walker, a cane, or walking behind a wheelchair. Also, dressing or grooming, because dressing is a program that can be used to teach and reinforce the selection, obtaining, putting on, fastening, and removing clothing independently. Then grooming is a program that works with an individual to maintain personal hygiene. And that includes gathering up their supplies, combing and styling their hair, making sure they're washing their face and hands, brushing their teeth, shaving, even applying makeup is actually part of a grooming program. And then eating and swallowing. And you may not see too much with eating with your caregivers. Eating was a program maybe that they had received in the nursing facility prior to discharge to home, where someone was helping them to get the food or drinks to their mouth, where they couldn't independently do that. Swallowing programs are designed for someone who may have a history or currently has a deficit in swallowing. And this is where they may need reinforcement in areas such as teaching on the size of the bite, chewing their food completely. Sometimes it's even a double swallow, a chin tuck, or even special fluid thickening instructions that can be worked with the family or the significant other and your patient or client. Amputation or prosthesis care is also a program where that individual was working with staff on self-performance, on teaching them on how to put on and remove the prosthesis, that hygiene care, and also similar to the brace or the splint, to really inspect for any skin integrity concerns as well. And then the last is communication, which may have been used when an individual had an identified need to improve or maintain their independence or self-performance in communication skills. Determining an individual's need for restorative nursing, keep in mind, not everyone will be appropriate for restorative programs, right? In fact, not everyone would have had a restorative program prior to your services. It all depends on the individual assessment, what their needs had been, their preferences, and the care team that took care of them prior to transition of care. So how do we determine the need for restorative nursing interventions? So let's talk about the importance and elements of a good assessment process, right? So part of that assessment process is looking at their history. Once again, history of function, prior programs for restorative nursing, or even prior interventions, as well as the individual's willingness to participate, because that's going to be important as well. Because if we look at that client's goals and desire to improve function, let's say you have a patient who is unable to independently move their right arm or hand, and you are worried about them developing a contracture. It is important for you to assess that prior participation and check that record to see, if that individual has had range of motion in the past, and have a good discussion with that patient, letting them know the benefits of range of motion, the risks of not participating. So, for example, if you don't work on range of motion on that limb, you could develop stiffness, which could lead to contractures, which could lead to pain and skin integrity issues. In order for that individual to make an informed decision, and then we want to document that we've provided education in that patient decision. Next, looking at their diagnoses, because some, based on their diagnoses, may not be, even a candidate. Also looking at function and a functional assessment. Has there been one done in the past? And does your pre-admission information include functional abilities on prior function? And then also collaboration. If formal therapy is coming into the home to see the individual, you can certainly work with, collaborate with formal therapy as well, so that you can develop a person-centered plan of care that specifically addresses function, approaches that can be used, such as teaching and really working with that family or that individual, including identification of any early decline, working with those families, and even if formal therapy is there when you're there, if necessary, having a discussion on what can be done to prevent functional decline, or to address any concerns before they become a problem with safety or functioning. Also, do you have policies and procedures on monitoring function with caregiving and follow up on any potential restorative interventions that are in the care plan? Really using any best practice approach, such as good communication at that transition of care is one of those best practice approach to look at what has been used in the past. What is their function upon admission into your services? What is your process for observation of their function and early identification of decline, and including therapy if they're involved? Also, taking a look at any compliance issues following that person-centered care plan to keep that individual safe and at their highest level of functioning. Also working with staff education, and Tiffany will be addressing this in a few slides more in detail. And then also relationship with formal therapy. Certainly, you don't set up the formal therapy services, but if that individual is receiving therapy, they can provide caregivers with suggestions so that the caregivers can reinforce exercises, approaches, or teaching. And then making sure that if we have any program identified in the plan of care, that we implement that plan of care and that we evaluate and oversee. And then also, how can the team assist in quality outcomes? And then, of course, with any type of care that we provide, if what we're doing isn't working, right, then we need, or if the individual patient or client does not prefer to have those programs, we need to revise those programs based on both that function and those preferences. So in order to have a successful restorative nursing process, we need to have well-educated and competent caregivers to be able to provide services that are assessed as needed. So let's talk about some strategies to educate caregivers for implementation. So Tiffany.
Educational needs of the nursing staff, ongoing training. What does our training program look like? How often do we have educational opportunities? Are we only providing the minimum requirements? How do we handle professionals who need more training? It is important to consider the benefits of looking at training programs as a benefit to your goals. A lot of times we look at training as something we have to do or are required to do. I implore you to think about training as a way to achieve your organization's goals. So for today's topic, restorative care, we can look at training as a way to promote improvement or maintenance of the functional ability of our clients and patients. The right training on the right topics can promote quality care and drive functional outcomes. We want to train our staff on the importance of promoting the client's ability to adapt and adjust to living as independently as possible. We want to promote the client's ability to reach their highest level of function. We want to train on ways to incorporate restorative care into our daily care each and every day. We are looking towards a long-term goal, not just meeting an immediate need. Our training may need to be ongoing to fully meet the needs of our staff and clients. Overall, we want to be proactive versus reactive. You may ultimately decide that your program will need more than the quote-unquote required training. More training in the beginning of a training process is typically less expensive and less time-consuming than a program that is now reacting to a shortcoming and now adding in additional training and steps at a later date. We would rather anticipate the needs and challenges that our professionals will see on a daily basis and encourage them with solutions and processes to combat the struggles and hurdles that may be presented. Knowledge is always power. How are we verifying competency? Are we providing ongoing surveillance? Remember, a restorative program is a program that you want to be successful over the long term. More than one competency check may be required and needed for the overall success of the program. Training implementation. So what will this program look like? The first thing we need is admin buy-in, right? We need the green light that this is something that we can create and that we have the admin support to maintain it. We also need someone or a small group to really own the task of being the leader on creating, implementing, and maintaining the training program. We want to find out what are the requirements and guidelines for a program such as this. Once we look at the minimum requirements, we then want to take a step back and ask ourselves, does this meet our needs? It may meet the requirements, but we may want to take it a step further and make sure that it also meets our needs. We want this program to be successful, and sometimes that means going above the minimum requirements and adding additional content. We also want to think about our program in the terms of what we need to provide to everyone for successful implementation, but also what do we need to provide to them ongoing? How do we keep this program successful, and how do we meet the needs of our professional staff ongoing? How do we get this information to our professional staff? I really want to encourage you to lean into technology. Technology, of course, is not new to us. It is only evolving more and more, and is really something that can save your organization time and money. There are many learning management systems or LMS systems out there, and they all provide a way for you to get your content out to all of your staff quickly and easily. It is typically very well received by the learners, as training content can be accessed by them at their convenience. They do not have to reschedule work or personal life to attend trainings. Instead, they can have access to them online 24/7. Now, should everything be presented virtually? Maybe or maybe not. This really is a decision that has to be made by each organization. Maybe some content is presented virtually and some is in person. Utilizing technology to benefit your team and organization is fantastic, but you may have some content you ultimately decide is still done in person, and that's okay. Creating a program that you feel best meets the needs of your team and organization is always the top priority. You can combine many aspects of training to make it an all-around effective program. Just a few examples are job shadowing, workshops, online courses, and on-the-job training. So the big part of restorative care is really creating a change in perspective. Many of our professionals want to help their clients with everything they can to make their lives easier. But we have to remember that in restorative care, our goal is to promote independence. And independence comes with keeping our clients active. We want to encourage them to do as many things on their own as possible. We all know that when it comes to our bodies, when we stop using something, we can quickly lose that skill or ability. So instead of pushing a "let me do that for you" mindset, we want to move to a mindset where we encourage our patients and clients to do as much for themselves as possible. We want to improve and or maintain as many functions as possible, as this directly equates to independence for the client. Ongoing surveillance and maintenance is important. You may want to consider a coaching and mentoring aspect to your competency checks. Consider job shadowing or on-the-job training as a way to maintain and provide that ongoing surveillance. We want to provide our professionals with tools to be successful. If we see that additional training is needed, we want to quickly and efficiently fill in those needs. We also want to promote an open door policy in regards to professionals knowing that they can come to admin with questions and concerns in regards to the program. We want to utilize feedback on our program to continue to adjust and perfect the program. In my mind, we are always modifying our programs to make them better and more efficient. Now, an example of a restorative program. In this example, we have clients who are receiving grooming and shower services from our HHAs in an assisted living facility. The HHAs were providing this service with a doing for mindset for their residents. While this can be effective in the short term of getting the job done, we know this results in a loss of confidence, added dependence on our HHAs, and overall physical deconditioning. We trained the HHAs on providing verbal cues, task segmentation, and supervision of tasks. We also provided training on the physical and mental benefits that the residents would experience with them maintaining and even improvement in their overall independence. We ensured that all HHAs were trained and also supported with a lead nurse and a lead HHA to provide competency checks along the way with job shadowing, on-the-job training, and a mentorship program. This is what led to a consistency of services being provided across all residents from all HHAs. A quality training program can equate to enhanced adherence to overall consistency of the care plan being provided. So to sum up the program, it first included virtual courses on our learning management system. We then added job shadowing and on-the-job training. We then maintained the program with competency checks and a mentorship program. We identified a lead RN and a lead HHA to really own the program and facilitate the proper care strategies by each resident's needs and abilities. They looked at each resident and asked, what can the resident do? What does the resident do for themselves? And what will the resident do for themselves? And started this person-centered approach for each resident. Long-term, what we saw for the residents was an overall level of either improvement or maintaining their current functional independence. We also saw an overall level of improvement on the residents in regards to their own sense of autonomy and independence, as well as overall mood and mental health. Sue, I'm going to pass it back over to you.
Okay, thank you very much, Tiffany. So there are many benefits to restorative care and services for the customer, the organization, and even for employees. So we're going to talk about some of those benefits. So let's start with the patient, client, or customer benefits. The first is to attain their functional goals, right? Because all goals will include their preferences and also really taking a look at what their function actually is and where they would like to be in order to improve their dignity, in order to also improve their function for safety. Next, moving into that dignity and feeling of self-worth, we know that when a person can do more for themselves, it's easier for them to get around, perform more of their ADLs. It does promote dignity and self-worth, and it gives them more freedom because they're able to move around and do more for themselves. Also, to promote adaptation to physical and medical changes, because part of what we do in healthcare is to continually assess, monitor for changes, and then put interventions in place, including the preferences of the individual, to promote that healthier and more independent lifestyle whenever is safe and possible. Also, to maintain independence, because independence is important to most people, and then to prevent functional decline. And then we also have benefits for the organization, which would be delivery of that quality of care and remaining competitive in the industry. I want you to think about how when satisfied customers, they tell other people, right, when they're satisfied. So therapy companies will tell others when they see quality programs and outcomes. Your patients or clients and their families will tell others when they see outcomes of greater independence and dignity and self-worth. And even some of the medical providers and other partners that you work with, they will also tell others when they see that you have positive outcomes. Now, there's also employee benefits. As your patient or client can do more for themselves, it reduces the workload of the caregiver as well. It also helps to enhance the relationship between those clients and the care provider. Also, with employees, motivation and job satisfaction. Most employees that you have job satisfaction in seeing that what they're doing improves the care of your patients, because most people go into healthcare because they want to help other people. And seeing that quality will also provide them, certainly, with better job satisfaction. Also, it will boost communication, and it helps them with professional growth as they learn more about restorative care and what they can do to help and different approaches that they can utilize in the different programs, because many times caregivers aren't even aware of all of the different restorative programs that can be implemented and utilized to improve or enhance individual function. So when we take a look at best practices in action, again, we talked about this today, about how it is important to identify individuals' needs based upon assessment and preferences. And part of that assessment has to do with taking a look at, remember, what function that individual actually has, not what we think, not what they did 2 months ago, but what actual function do they have today, and what are their needs, so that we can be able to develop that person-centered plan of care. And part of a person-centered plan of care will require us as a team to utilize not only their history, but also their preferences, to include that family, or if they have other significant other caregivers, and then also all the caregivers that work together with helping that individual, so that we can put together a meaningful person-centered plan of care that will be successful moving forward. And then we want to evaluate that individual's response to interventions. If what we put into place, sometimes the best planned approaches aren't always the best approaches, and we try them and they might not all work. So we may need to revise some of those interventions. If we have certain goals and that individual isn't meeting those goals, it doesn't necessarily mean we have to change the goal. We may need just to tweak some of those interventions, because if that's a goal that that individual wants to meet, let's try looking at some of those interventions. That might be pain management. It might be they need a walker instead of a cane. Whatever the case may be, let's take a look at some of those interventions first, if we have a goal that seems to be realistic for that individual. And then if none of those work, then we can revise that plan as necessary. But we really want to work as a team to make sure that we have some successful person-centered care plans that are communicated to the entire team, so that everyone is on the same page. Also, that preparation. Any type of pre-admission needs to include whatever programs they had been in the past, whatever therapy interventions have been utilized to have been successful, even looking at those that weren't successful, because we don't want to use those if we know that they've been tested with this individual patient or client and they haven't worked. We want to make sure that we're asking the right questions and that we have good communication. What restorative programs were successful? Because again, sometimes people don't need to be on a restorative program, and certainly individuals don't need to be on all restorative programs. So what was used? What interventions were reasonable? What should we reinforce because they've been effective in the past? And this is really important. Are there strategies that we can use to prevent decline? There may be some people who love to sit in their recliner all day, but as they sit and fall asleep, they're not moving around. Sometimes they don't put their feet up. They end up with edema and they're not moving as well. And remember how a good program will help the circulation, the lungs, everything, even the mind. So what strategies can we use as a team, including that patient and family members, to prevent that decline? And how can we get them out of that chair if possible? Also, some takeaways, tips, and resources. The first here, the importance of function is really crucial because function can lead to, if they're not moving around, it can lead to other health concerns. It can lead to depression. It can lead to feelings of not having that self-worth and dignity that they need. And keep in mind, these programs are so important, including toileting, walking, even how they groom themselves, how they can walk around in their own home, or even going outside. We may need to even have to work with them on looking at surfaces, because they might walk very easily inside the home. But what happens when it comes to outside and then in the grass, and how do they get from the grass to the cement? Because there might be a little lip that we want to teach them so that they don't trip. And we want to make sure that whatever we look at for their programs are successful for them to stay as independent as possible, because function is crucial. Next, we do need their involvement in that plan of care to really take a look at optimal outcomes. Because if they don't want to be involved in it, or if it's not important to them, then two things can either happen. Number one, we can educate to them and explain the importance of function and how this can help in other ways. Because yes, walking may be difficult today, but if we do a little bit at a time, we can really work on endurance. And the farther they go, the better they may feel. And working with explaining to them why it's important to work together. And now, Tiffany, I'll have you talk about the next three areas here.
Sure. The importance of education and the competency of your caregivers needs to be at the forefront of your mind. Our caregivers must understand the tasks at hand and be able to carry them out fully. Transition of care communication is so important for our success. We have to take note of the client's condition. What services were they receiving before us? And then we can adequately understand their needs as they come on to our services. And also the importance of the role of function and overall health is huge. We all know that when we stop moving or using a skill, we likely lose it. Keeping our daily functions has a huge effect on our physical and mental health ongoing. Back to you, Sue.
Thank you, Tiffany. So it's important to remember that transition of care communication is going to be so important because that gives us the first look at what potential restorative services we can provide for our patients and clients that potentially have been used prior to admission to our services. And then next, we can also collaborate if that individual patient or client is seeing formal therapy because they have a function, either a decline or a deficit that they could potentially work upon, because we could work in collaboration. Some of the programs that we can use certainly would be our ambulation or walking to keep them at their highest level of functioning. We talked about transferring and teaching safety with transfers and really providing them with some good interventions to be able to use. And we want to include the family members or significant others in the process because we're not necessarily always there for every transfer. Also looking at bed mobility and teaching them some significant areas for safety and the importance of moving in bed. Also, taking a look at even dressing and the importance of collecting the supplies and choosing their clothing and then making sure that they know how to put that clothing on and take it off and when it needs to be laundered. And then also looking at special hygiene needs when it comes to grooming and shaving, and sometimes even with individuals in the home that have some cognitive deficit. Some of the interventions that work really well with them are practice and repetition, because sometimes sequencing, they sometimes forget to put things in the right order. So it's that practice and practice and practice. So we want to teach our caregivers the importance of patience, because it does take longer for caregivers. And this is an important area to remember. It takes longer for caregivers to teach and practice and work with an individual than it does to do it by themselves. So one of the key areas caregivers need to remember is they need to take the time and have the patience to work with an individual to become stronger and more competent themselves in being able to remain as independent as they possibly can. So I would like to open it up now. We have a few minutes left here for questions. So I would like to open it up for any questions that anyone has.
There is one question in the Q&A. Will Medicare/Medicaid pay for restorative nursing? Do we have to have a physician order?
So Tiffany, in your setting, is that covered for restorative nursing?
Typically not on our end. It's typically not going to be covered.
And I think too, many times when people ask about a physician's order, one of the things to keep in mind, and I'm going to say this, it all depends. Because if we're, for example, looking at some range of motion exercises on an individual that has some type of deficit, arthritis, we would want to have a physician's order to be able to perform that range of motion. When it comes to walking, transferring, dressing and grooming, those programs can be put into place based upon an assessed need. Other questions?
Okay, there's another one. How many weeks are restorative nursing approved by insurance?
So in the home, Tiffany, are there a number of weeks? I'm not familiar with the number of weeks that are approved for insurance. Restorative nursing, and I want to preface this, and then I'll let Tiffany weigh in too. Restorative nursing is something that actually can be performed without getting extra payment for it, because it's actually sometimes used as a service that's necessary to keep someone at their highest level of functioning. And I do see here, does restorative require to be certified, and what type of certification? The staff performing restorative services need to be trained in restorative interventions. Tiffany, do you have anything to add to that?
Yeah, in general, the services that would come from, an agency such as ComForCare, where I'm from, unfortunately, the typical insurance is not going to cover those services, regardless if they are restorative services or, any other services. So I just wanted to add that in, that typically just with the non-medical home care, we're not necessarily looking at your typical insurances being covered. But things that can cover would be long-term care insurance. And also if someone is participating with the Medicaid waiver program, that's also a spot where those services could be covered.
There's two other questions. Isn't restorative nursing similar to PT and OT? And then there's another certification question regarding where can our CNA become certified?
Okay, so restorative nursing can be similar to PT and OT, because many times what happens is once formal therapy discharges someone into just general care, they then can provide interventions in communication to the caregivers on what services can be implemented then that are considered general care, general restorative care, to then move forward after therapy discontinues. And typically, when it's nursing restorative, it's under the direction of nursing or under the direction of the organization that's providing it, whereas when it's under therapy, it's under the direction of therapy. And CNAs can get their certification for restorative nursing. There are certain technical schools, I believe, that offer courses throughout the country to become certified. But CNAs don't have to be certified. They have to be trained. It's nice to have the certified CNA to do restorative services, but it's not a requirement. CNAs can be trained to perform range of motion, ambulation, toileting, transfers, bed mobility, swallowing, all of those types of things. They can be trained to be competent in providing those interventions to improve or maintain function. What constitutes an eating swallowing program? So eating programs would be for someone who has difficulty getting their food or fluid to their mouth. So it would be someone who would be teaching them. Sometimes it starts out where it's almost like a hand over hand and teaching someone to get that food or fluid to their mouth. There may be a combination of equipment, certain divided plates. Sometimes what happens, for example, it might be someone who is one-handed. They don't have two hands. So you may get that non-slip material to put underneath the plate that's divided so that the individual would be able to learn how to be able to scoop their own food and get it to their mouth as independent as possible. For example, swallowing is a separate program that when you have an individual who has an identified swallowing deficit, and that is where therapy, speech therapy, would then have provided some good communication on interventions that would be successful for an individual, such as reinforcing the size of the bite, alternating solids and liquids, Sometimes some individuals benefit from a double swallow or a chin tuck, but not everybody. Some individuals are recommended to have thickened liquids. And so those would be the types of interventions that could be used for eating and swallowing programs.
Listeners, visit ComForConnections.com to download complimentary resources, view show notes, and access our episodes. You can also subscribe to our podcast on your favorite app. Thank you for listening and helping older adults live their best life possible.